Hello, everyone. My name is Zhe Lim. I'm currently an SHO in the oncology department in St. George's Hospital. But the audit that I did and the one that I'm presenting today is one that I've done in my resident doctor years, 2 years ago, in Buckinghamshire Hospital. And it's about the use of tranexamic acid or lack thereof in general surgery. And I've named it a low-hanging fruit, as you'll soon discover why. So, a bit of background. Surgical bleeding is very common, and it is unfortunately a major cause of morbidity and mortality in patients. Patients who bleed intraoperatively will often suffer from increased prolonged stay in hospital, increased risk of infections, and increased risk of death. Usually, blood transfusion can solve a lot of these problems. However, it is a scarce resource. It is expensive, coming in at about 150 to 200 pounds per unit, and it carries its own risk to the patients, things such as infection, immune modulation, and transfusion-related reactions. Tranexamic acid, on the other hand, is a cheap, cost-effective, and widely used drug, coming in at just about £1 to £30, depending on where you use it. That is often overlooked. And I'll go over sort of how it works in a minute, but how it works in surgery is to prevent major hemorrhage. It has been shown in previous studies to improve surgical outcomes by preventing the need for transfusions, reduce the risk of bleeding/infection, and ultimately reducing the inpatient hospital stay times. So tranexamic acid is an antifibrinolytic drug. It acts by binding to plasminogen and hence preventing it from being activated into plasmin. Now, plasmin acts to break down fibrin, and hence by giving someone tranexamic acid, it shifts the coagulation pathway towards clotting and away from bleeding. So this is how it works. The audit is benchmarked against the current guidelines that we have from the Joint Royal Colleges. And it's quite a recent guideline, actually. It's only been published in 2022. They recommended 1 gram of tranexamic acid to be given before skin incision, and then again, another gram to be given after skin closure for all adults undergoing moderate risk colorectal surgery. This is further supported by our NICE guidelines in the UK, who recommended all adults who are having surgery and expected to have moderate blood loss, defined by 500 to 1,500 mils, to receive tranexamic acid. A further POISE-3 trial also determined that TXA reduces major bleeding by 25% without increasing the risk of thromboembolic events such as PEs. The aim of the audit is to evaluate the use of TXA in the general surgery departments to encourage compliance to the current guidelines that we have, and to look for any positive change in practice after presentation and making changes. So what we did was we analyzed all moderate risk colorectal surgeries performed at Stoke Mandeville Hospital and Wickham General Hospital from 1st of September to the 31st of November. We looked at whether tranexamic acid use was documented and given in each case, both doses. And subsequently, we also looked at the number of cases, the number of patients requiring transfusions or iron replacement therapy. A total of 96 cases were included, of which 2 were excluded because of lack of documentation. There is an even split of elective versus emergency cases. We categorized the surgeries by laterality. Surgeries include anterior sections, hemicolectomies, laparotomies, Hartmann procedures, and so forth. The mean age of our patients is 68.6, with our youngest being 14 and the oldest being 90. We have quite an even male to female ratio, as you can see there. And importantly, the mean HB levels or hemoglobin levels of our patients before surgery was 123. So this is what we found. Out of the 94 cases observed, tranexamic acid was only given in 17 cases. And out of those 17 cases, only 4 patients received the correct recommended regime of tranexamic acid. This reflects 4% compliance, and I think that we can do better. Subsequent analysis on the requirements for transfusions or methods to raise the HP levels up post-operatively showed that about a quarter of patients, or 25%, required some sort of intervention. You can see that 19% of them actually required transfusion after surgery. Now, shifting our focus to blood loss intraoperatively, you can see there on the graph that majority of patients actually did not really sustain much blood loss. But this further reflects the fact that we already know that tranexamic acid prevents blood loss, because in cases where both doses were given, patients only sustained less than 50 mils, which is nothing in blood loss, whilst those given suboptimal doses sustained 40 to 700 mils intraoperative. Now, if you look back to the previous slide, a large proportion of patients actually required some sort of intervention, be it blood transfusion or iron therapy, to raise their blood levels up. But this is not really in line with what we found in terms of blood loss intraoperatively. That can be explained by a few methods, but what we found was that about half, or 49% of patients, were actually anemic before surgery. And this is defined by less than 130 for men and less than 125 for women. It is highly likely that it is this group of patients that would most benefit from correct tranexamic acid use, because it is highly likely that this group of patients were pushed under transfusion thresholds after surgery, despite minimal blood loss. So in conclusion, there's low rate of tranexamic acid use, at least in the general surgery department that I worked in, and even lower rate of correct tranexamic acid use. Remember that our guidelines recommended 2 doses to be given. And ultimately, transfusions and iron replacement therapy could potentially be avoided, saving the NHS a lot of money if we follow these guidelines. So the results of the audit were presented locally and regionally around Buckinghamshire Healthcare Trust. And we are in the process of making it a routine consideration for all adult patients, including ultimately adding it as part of the WHO checklist. This can remind our anesthetic and surgical colleagues to administer tranexamic acid before surgery. And subsequently, there is an audit going on right now to look at the total cost that we save after intervention, and to look for, again, any positive change in behavior. So that's the end of my presentation. Thank you very much.